Good morning, everyone. For this morning's session, we are going to discuss the physical examination of the ears, nose, and paranasal sinuses. So again, I'm Dr. Ann Angelica Macalalad-Josue. I'm one of your teachers. So at the end of the class, the student should be able to review the anatomy of the ears, nose, and paranasal sinuses and correlate it with the physical examination. And then lastly, you guys should be able to perform the physical examination of the ears, nose, and paranasal sinuses. So let's just have a brief review of the ear. So the ear has three compartments: your external ear, your middle ear, and your inner ear. So your external ear begins with your auricle. And your auricle is mostly composed of cartilage and thin skin, and it's also elastic, no? You can move it freely. And then next would be your ear canal. So your ear canal is the outer ear canal is hairy. It has hairs. So when you insert your otoscope, you can actually see hairs, and it also has glands in the outer portion that produces your earwax. In the inner ear canal, it only has, so the outer ear canal has cartilage underneath, but in the inner ear canal, you have your underlying bone and thin skin. So this part is already hairless. Okay, so any pressure on this area of the ear canal causes pain. No? So when you try to insert your otoscope, make sure it's not very inflamed, because when you insert it further, it can cause discomfort or sometimes even severe pain on your patients. And then next would be your mastoid process. So it will be behind your pinna here, over here. You can see it as a bony prominence here. I hope you try to feel your own mastoid process. It's the bony prominence behind your ear. And then next, you have your tympanic membrane. So this is your tympanic membrane. So your tympanic membrane demarcates your middle ear from your inner ear. And your inner ear is anchored to your auditory ossicles, your malleus, your incus, and your stapes. Okay. So when you look at your inner ear, when you look into your ear canal using your otoscope, it should look like this. So this thin film here, the pearly white thin film here is your tympanic membrane, or your eardrum. So it's usually described as pearly semi-transparent film. No? It separates your middle ear from your inner ear. And you can actually see some of the auditory ossicles, particularly your malleus, with a normal tympanic membrane. If the patient doesn't have any earwax or any obstruction in the ear canal. So the landmarks that you will see will be the short malleus, the short process of the malleus, and the handle of the malleus, or the long process of the malleus. You should be able to see that when you do your otoscopy. And then you will see the one that connects your malleus to your eardrum, where the eardrum meets the tip of the malleus, is called the umbo, and beside that will be reflection of light, called the cone of light. So the reflection of if there is the cone of light, it's not intact, you cannot appreciate the cone of light, then there's an abnormality in your tympanic membrane. So it's the reflection of light called cone of light. So if you illustrate this, this will be your left ear and your right ear. So your left ear will have the malleus pointing left ear. So sanay kasi ako sa right ear, left ear. So let's begin with the right ear. So the right ear will have your malleus pointing outwards and also your left ear pointing down, outwards also. So, yeah. Later on, I'll show you how do we illustrate this. So, let's choose color green. So usually when you draw this in the chart, usually we draw the right ear and then the left ear. So how my ENT resident taught me, you make a circle like that, and then you make a drawing like that, and then you make a cone of light like that. So that's how we draw it in the chart. And then you have your ear canal. And likewise, your left ear, like that, and then your cone of light, and then your ear canal. So, for example, you have cerumen here, cerumen here, cerumen here. You can draw that in, or let's say partially your ear canal. Can you see it? And sometimes you can see black perforation here. You can draw that also, or a perforation here. You can also draw that when you document your findings in the chart. So usually when you document findings in the chart, you don't really write it down in words, but it's better to draw it, to illustrate it. So this is how we usually do it in the clinic. So when you have your ENT rotation, you will be able to learn how to do this. And when you do the actual examination of patients. So how do we, so the ear has several pathways of hearing. You have the conductive phase. The conductive phase is when the vibrations of the sound travels through the air from the external ear to the middle ear. So, and then the sensory neural phase will be when the impulses created by the vibration is transmitted from the cochlea to the cochlear nerve. So if there is any defect from the outer ear to the middle ear here, you will have conductive hearing loss. If the problem is in your cochlea or your cochlear nerve, you will then have your sensory neural hearing loss. So you can actually detect or differentiate between the two using physical examination. Your conductive phase, this part can be different, can have two kinds. Now you have your air conduction where the vibration of sound travels through air, and you can also have an alternative pathway called the bone conduction. So for example, the vibration is felt in the bony area of your mastoid process. This vibration of the bone can be transmitted, no, and detected by the cochlea, and it will be perceived as a sound. No? So that's your bone conduction and bypasses your conductive phase, bypasses your external ear and your middle ear because it goes straight to your inner ear. So you will be able to test that also during your physical examination. So air conduction is the normal phase in the hearing pathway. The bone conduction bypasses, as I mentioned earlier, the external and the middle ear and is used for testing purposes. So we test for bone conduction if we suspect that you have you want to differentiate whether this is a conductive hearing loss or a sensory neural hearing loss. Next, we review the surface anatomy of the ear. Of course, you're familiar with the nose, the tip of the nose, and of course, you have your ala nasi and your anterior nares, and the inside cavity will be your vestibule. So the first part of your nasal septum is cartilaginous, and then the inner part will be bony. But the one that you'll be able to examine will be only the anterior part of the nasal septum. Now, if you want to examine this part, no, of your nasopharynx, no, it's actually possible to do a physical examination, but you will need special instruments. So, these are the instruments that our ENT colleagues use. No, you have your ENT head mirror, your nasopharyngeal mirror, and your nasal speculum. So we don't expect you to have this at home or for your personal use unless you want to go into ENT. But when you go into the clinics, when you go into your ENT rotation, you will learn how to use this instruments when you go into the clinics. It's actually very cool to see using the head mirror and the nasopharyngeal mirror. And then next, we go to your paranasal sinuses. So your paranasal sinuses, before we go to your paranasal sinuses, inside of your nose, you will be able to observe the lower portion of the turbinates. But when you cut your head into half, you will be able to appreciate the three turbinates are superior, middle, and inferior turbinate. But the only part that you will be able to examine is really just this part, the inferior turbinate. The rest you cannot examine anteriorly. So the turbinate serves to provide additional mucosal surface area, and your nasal mucosa functions in cleansing of the air, humidification, and temperature control of your inspired air. Next would be your paranasal sinuses. So your paranasal sinuses are air-filled cavities. So they make your skull lighter. So just imagine if they're solid, your head will be too heavy. So they make your skull lighter, and also helps you transmit sound better. And so there's your turbinates, and your maxillary sinus and your frontal sinus, your ethmoid sinus. But for your physical examination, you will only be able to examine the frontal and your maxillary sinus. So externally, you will be able to appreciate the frontal sinus here, but you will usually be examining it from over here. And your maxillary sinus is over here. Okay? Very easy to examine. So now we go to the ear examination. So the first step will be to inspect the ear. So you inspect the outer ear, palpate the ears between two fingers for any masses or tenderness. So here you will be able to feel a bony prominence. It's your mastoid bone. During this time, you can actually start to ask the patient if she's been having any problems with their hearing. And then when you inspect the pinna, you look in front and behind also. Look at the skin, look for any lesions or scars. There's your ear piercing. And then you can see in the preauricular area, you can see a tiny hole there. Now, it's a common place for sinus drainage. If you see a hole there, that's actually a sinus drainage. And then also check for the condition of the cartilage because it can have some deformities. You can also do the tug test. You just pull on the ear. Any movement of the auricle and the tragus is painful in acute otitis externa. So look for any so you just talk. You ask the patient, is that painful? Or sometimes you don't even have to ask, they will complain. Ay! So that's a sign of acute otitis externa. So other things that you have to look for, any deformities, any lumps, or skin lesions. So you can see this in children. This is called your preauricular pit. That's a congenital. It's a very common congenital deformity. And then you can also have basal carcinoma of the ear. And then you can have also some tophi in the ear. That's also can be seen with patients with tophaceous gout. You can also observe tophi in the ear aside from tophi in your joints. So when you see that, you can examine the joints and look for other tophi. This one, a joint deformity, you see in lepromatous leprosy. So some of those with severe leprosy can have very, very deformed ears. Next, we go to the ear exam. So when you do the examination of the ear canal and the tympanic membrane, you will need to use an otoscope. So although we don't expect you to have otoscopes at home, no, so don't worry. When you go into the clinics, you will be able to experience that. Although it would be nice, no, to have your own, although it's a bit expensive, but it would be nice to have your own. But we will ask. So, but at this point, you're not required to have it yet. So to see the ear canal and the drum, we use the otoscope. So when you hold the otoscope, you hold it like a pencil, no? And then you anchor your hands, no, lightly against the patient's face, just very lightly, no, to steady your hand. And then insert the speculum gently into the ear canal. If you see that the ear canal is very inflamed, don't even try to attempt to push it down further because that would be very painful. So usually we wait for the swelling to subside, maybe prescribe the patient with some antibiotic if it's necessary or some ear drops too, or clear the ear canal first, no, before doing an examination of the tympanic membrane using your otoscope, no? So you direct it somewhat downward and forward. So note any discharge, foreign bodies, redness of the skin, or any swelling in the ear canal. So normally you hold it like that, but when you try to examine it, no, in the ear, you hold it like a pencil, okay? And then, when you insert your otoscope, we try to straighten the ear canal by pulling the auricle posteriorly and superiorly. So you pull back and upward. So posteriorly and superiorly to straighten out the ear canal. So you will be able to visualize the tympanic membrane more fully. Okay? So you have to examine both ears, of course. So again, this will be how you will normally see a normal tympanic membrane. And then there's also what we call a pneumatic otoscope. It's a tube that we attach to the otoscope. No? Usually the ENT doctors are very good at this. You'll be able to observe this in the clinics. And then we can inflate air inside and you will be able to see the movement of the eardrum. Okay, so any problems with the mobility of the eardrum can signal different pathologies. So again, you will be able to see the malleus, the short process, and the handle, and the umbo. The umbo is anchored to the eardrum. And this is your pars tensa, and you will see the cone of light over in this area. We already did the illustration earlier, so I'll not repeat it again. So look at this eardrum, what do you see? Is it normal? Okay, you have your cone of light here, but look at the color behind the eardrum. Do you see something yellowish? I hope you see it. This is actually a serous otitis media. You will see a bulging an amber-colored eardrum. The amber color behind is actually a serous effusion. So usually, if you do a pneumatic otoscope, no, there would be decreased mobility of your tympanic membrane. So other conditions that can cause decreased mobility of your tympanic membrane, aside from a serous effusion, just like here, you can have a thickened eardrum. Now, usually when it's a thickened eardrum, it looks very opaque, no? Very white. It's not semi-transparent anymore. It's not pearly white. No? Or you can also have purulent otitis media, which I will show you in the next slide. So this is your acute purulent otitis media. If you can see, the tympanic membrane is very angry. No? It's red, no? And you can see the bulge, and you can see the purulent discharge behind the tympanic membrane, no? Pushing out and bulging out the tympanic membrane. So that's your acute purulent otitis media. So how about this one? What do you see? Can you still visualize the tympanic membrane? So if you see some lumps over here, what do you think this is? So this is actually cerumen in the canal and also impacted into your tympanic membrane. So for you to be able to fully examine the tympanic membrane, you have to clean this out. No? So usually you will be able to observe that in the ENT clinic. So sometimes they flush water or they use suction machines to suction out the cerumen inside the canal. So this is your wet cerumen. So sometimes the cerumen will be dry. So this will be dark brown or black in color and very dry, not shiny. So you can also have dry cerumen. Sometimes you have to loosen it up with some fluids to make it softer so that it will be easier to remove. Next, this one, what do you think this is? What can you observe on the tympanic membrane? So you can observe some bullae, just like in your skin, you can observe some bullae in your tympanic membrane. It's also bulging. And this is your bullous laryngitis or bullous infection of your middle ear. So this shows the large vesicles or bullae visible on the eardrum, and you will not be able to see anymore your landmarks, your short and long process of the Marius. And you can also see that the drum is reddened. You see the prominent blood vessels, no? And this is usually caused by a viral infection and can have painful hemorrhage as well. This one is acute otitis externa. So it's the outer ear that's inflamed in red. So you can see that the canal is narrowed. No, it's narrowed, no, because it's either swollen or the skin surrounding the canal is swollen. No, that's why the canal is narrow. You can hardly see the tympanic membrane, no, inside, no, and you can also see it's pale and most often than not very, very tender. So be careful when you examine this kind of patient. Next, this one, no, this one is traumatic perforation. You can see a hole, no, in your tympanic membrane, no. Usually, it can result from purulent infection of the middle ear, and the purulent infection can cause holes in your tympanic membrane. No? You can describe the perforation of your tympanic membrane depending on its location. So this one is a central perforation of your tympanic membrane. So if the perforation is over here, no, that's your marginal tympanic membrane perforation. Okay. So this one, sometimes you can see patients with this kind of tube. This is a tympanostomy tube. No? It is sometimes placed in children with series of ear infection. No? Major goal is to prevent conductive hearing loss, which may prevent delayed language development. So sometimes they can hear, their ears are very sensitive. Next part of the examination will be your auditory acuity. No? So you need to test both ears independently. So first, you cover one ear and you ask the patient to close her eyes so that she will not be able to see you. No? So you can rub your finger, no, 3 feet and ask the patient whether they can hear it or not, and then you can ask the patient to point if once she starts hearing it. No? So you can move your fingers closer to the patient and can approximate auditory acuity. So the person with normal hearing will be able to hear your fingers anywhere when you start at about 2 feet. But alternatively, you can also use your voice, no? So you can cover one ear and then you whisper something about 1 to 2 feet, no, away from your patient, and you can say words like 9 4. So you just whisper, and then you ask the patient whether she can hear you or not. Okay, so you will be able to see that later in the video demonstration. So you test each ear individually. So after testing the left ear, you can test the right ear, and if you see any abnormalities or any decrease in the auditory acuity, you can now proceed to the other tests. So the other tests would be tests of lateralization and lateralization, and also test to determine whether this is sensory neural versus conductive hearing loss. So your Weber test is your test for lateralization. So you can tell whether it's the right ear or the left ear that is the problem. So how do we do this? So let's say this is your tuning fork. I don't have a tuning fork at home. So you tap it lightly on your hand, and then the tuning fork will start to vibrate. And then you put it here in the center of your head, in your vertex. And then you ask the patient where the patient hears it, and only on one side or on both sides. No? In unilateral conductive hearing loss, the sound is heard or lateralized to the impaired ear. In unilateral sensory neural hearing loss, the sound is heard in the good ear. So the Weber test is not a standalone test. You have to correlate it also with your Rinne test, because the Rinne test will tell you whether this is conductive or sensory neural hearing loss, and the Weber test will tell you which side is it. Okay? So how do we do the Rinne test? So we test for air and bone conduction. So how do we do how do we do the Rinne test? So first, again, you tap your tuning fork lightly and place it behind the ear of the patient like that while it is vibrating. And then you ask the patient to tell you when they've stopped hearing the sound. If they've stopped hearing the sound, Doc, hindi ko na po naririnig. And then you place your tuning fork here in the air beside the patient's ear. This one represents bone conduction, and this one represents air conduction. So if you place the tuning fork here, the patient should be able to hear the sound still. No? So they cannot hear it anymore. So when you tap it here, they should be able to still hear it, the vibration. No? So that's normal. No? Or the patient can also have sensory neural hearing loss. So in sensory neural hearing loss, sound is heard longer through the air. So air conduction is greater than bone conduction. If the patient is heard through the bone as long as or no longer than it is through the air, it's conductive hearing loss. When you put it here, and the patient cannot hear it anymore, and you put it here, and the patient cannot hear anything anymore, so there's no more air conduction, it means that the air conduction is less than 2 or equal than the bone conduction. So that's conductive hearing loss. So it means that that the defect is in the external and middle ear. So I hope you can imagine that. No? So if it's conductive hearing loss, the bone conduction is longer than or equal to the air conduction. So when you move your tuning fork over here, the patient can no longer hear it. If the patient can no longer hear it, meaning this area will be the one that's the problem, that's your conductive hearing loss. Otherwise, it's your sensorineural hearing loss. And then you correlate it with your Rinne test. So if you detect from the Rinne test that it's a conductive hearing loss, then you can lateralize the problem if the sound is heard on the impaired ear. So for example, you do the Rinne test and you know that it's conductive hearing loss. And then you do the Weber test and then the patient can hear it on the right ear. It means that the right ear is the one that is impaired. Okay, now during the Rinne test, if you detect that it's a sensorineural hearing loss, then you put it here and the patient can hear it on your right ear, then the problem is on the left ear. Okay, so you need to practice this. Next, examination of the nose and the paranasal sinus is relatively easy. So you can use either an otoscope, or sometimes you can just use a simple pen light to examine the external part, or you can use a nasal speculum in a pen light also. So if you have it, you inspect the anterior and inferior surfaces of the nose. You test for nasal obstruction. How do you test? You cover one ear and you ask the patient if she can breathe freely. If she can, then there's no obstruction here. But if the patient cannot hear, it means that there's probably obstruction in the contralateral side, in the unobstructed vestibule. Okay, and then you inspect the inside of the nose using the largest ear speculum available, because the ear speculum, the attachments of the otoscope will have different sizes, so use the biggest one. And you should be able to see the inferior turbinate, the middle turbinate not so much, and you can also see the septum, so you can see if there's any deviation, if there's redness, discharge, So look for any swelling, bleeding, or exudates, and note also for the color of the exudates, whether it's reddish, whitish, yellowish. In the nasal septum, look for any deviation, any perforation of the septum, although I've never seen that. Any ulcers and polyps. Now, polyps are usually fleshy, semi-colorless outgrowths in the septum, so you can also see that. If you have the right instruments. Okay, and then lastly, we have the examination of the paranasal sinuses. So as I mentioned earlier, you can only examine the frontal sinus and the maxillary. So how to examine? To examine the frontal sinus, you palpate and press here, underneath the bony prominence here without putting pressure on the eye. Do not put pressure on the eye, just here. Now, if there's tenderness, then you say that the frontal sinus is tender. Here, you can also press here to check for maxillary sinus tenderness. Okay, so to show you a demonstration, this is video from the old version of Bates. Okay.
By inspecting the auricle for position.
Okay, let's start.
Begin the ear examination by inspecting the auricle for position, size, and symmetry. Also, inspect the opening of the ear canal for discharge, swelling, or redness. If the patient has complained of ear pain or if you see signs of inflammation, check for tenderness by moving the auricle up and down and pressing firmly on the tragus. Pain on these maneuvers suggests inflammation of the ear canal. Also, press firmly on the mastoid bone behind the ear. Tenderness here suggests middle ear infection. Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. Grasp the auricle firmly but gently, and in an adult, pull it up, back, and slightly out to straighten the ear canal. Then insert the speculum gently into the ear canal. Note any cerumen or earwax that may impair your view. Also observe for any discharge, foreign bodies, redness, swelling, or scaling. There should be none. Slide the speculum slightly down and forward and maneuver it until you can see as much of the eardrum as possible, including the pars flaccida if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the drum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner. For the next part of the ear exam, evaluate the patient's hearing. Occlude one of the patient's ears with your finger. Test the open ear by softly whispering numbers or words with two equally accented syllables from 1 or 2 feet away. Test one ear at a time. If hearing loss is present, gradually increase your voice volume until the patient can identify the spoken numbers or words. If hearing is diminished, do the Weber test, which checks for lateralization of bone conduction, and the Rinne test, which compares air and bone conduction. For each test, use a relatively high-pitched tuning fork, such as one of 512 Hz. To do the Weber test, place a lightly vibrating tuning fork firmly on top of the patient's head. Ask where the patient hears the sound, normally in both ears or the midline. To do the Rinne test, place a lightly vibrating tuning fork on the mastoid bone behind the ear. When the patient indicates that the sound is no longer heard, quickly place the vibrating fork close to the ear canal. Normally, the patient can hear vibration longer through air than through bone. Repeat the test on the other ear.
Tell me when it stops.
Summary. Examination of the head, eyes, and ears includes inspection of the head, hair, scalp, skull, and face. Tests for visual acuity and visual fields. Inspection of the eyes. Ophthalmoscopic examination. Inspection of the ears. Otoscopic examination. And tests for hearing.
Alright, so that's it for this morning session. So I hope you learned something today. So make sure you read the rest of the last the tables, no, at the end of the chapter. Review the different pathologic conditions of the ear that you can examine. You can observe in the physical examination for your review. So because some of it I did not include it anymore in the presentation. So I hope you learned something new today and have a nice day for the rest of your day today. Okay, bye-bye.